Hi, good day, dear colleagues. This is Dr. Jihad, and our today's lecture is a continuation to the series that we have started, What Surgeons Should Know. And today we are going to talk about endoluminal surgery. And to explain simply what do we mean by lower GI endoluminal surgery, in the previous lecture we talked about different instruments by which we can access the lower GI through the anus and rectum. For example, we talk about the anoscope, proctoscope, sigmoidoscope, colonoscope, and any intervention that we can do through these accesses is what we mean by endoluminal surgery. For example, removing polyp when doing colonoscopy is part of the endoluminal surgery. Okay. I think that some of you heard about the NOS approach or NOS surgery or natural orifice surgery. It is incisionless, accessing to the lesion in the body, wherever, through a natural opening. What natural opening do we have? For example, the mouth, the anus, the urethral opening. These are incisionless, and these are developing nowadays, and the revolution of medicine. In the past, we used to do open surgery with big incision, morbidity, of course, significant mortality, and the medicine developed a little bit step forward, and laparoscopic surgery take a place with a smaller incision, better recovery, and nowadays we are talking about the endoscopic or endoluminal approach if we are talking about the lower GI, so endoluminal surgery. Okay. Of course, we have advantages and disadvantages. You can imagine that you are going to remove a lesion, whatever it is, through the colonoscope. We have a flexible instrument. We have a small field to operate, moving field. So this is one of the challenges that may face us. This is a nice picture, shows you how we start with open surgery, then we move to laparoscopic surgery, and nowadays we are talking about endoscopic surgery. Okay, let's talk about some instruments. What do we need to proceed in endoscopic surgery, simply and briefly? And first of all, let's talk about the forceps. Okay, forceps that we may use through the endoscope during endoluminal surgery are classified to three types. We have two cold classic, cold jumbo, and hot forceps or hot biopsy forceps. Actually, the cold standard, this is it. This is the jumbo, bigger mouth. Actually, the cold forceps opens up to 6 millimeter, whereas jumbo cold forceps open to 8.6 millimeter. It's proven that the jumbo forceps is better for removing, for example, as you see here, polyp. Okay, what about hot biopsy forceps? What do we mean by hot? It's using a kind of electrocoagulation when we remove the lesion. Actually, with cold biopsy, what we do is avulsion of the lesion or polyp. In hot biopsy, there is a kind of electrocoagulation and fulguration. Theoretically, in the past, they thought that hot biopsy is better in that it will add a benefit of fulguration of the remaining dysplastic tissue by just cauterization. But when we review later the study, we found that that wasn't correct, and plus hot biopsy may cause a kind of partial thickness burn, which may develop to full thickness, which may invade the submucosa where the vessel is, and it is associated with delayed bleeding. And even the European Society of Endoscopy recommend against the hot biopsy. One of the classic indication for cold biopsy forceps, you will see that we will talk now in the next few seconds about snares, but now we are talking about forceps, cold one, which uses the avulsion. They avulge the tissue. One of the classic indication is what we call it, as you see here, LST, the lateral spreading tumor. These are lateral spreading tumor. They are superficial, can be classified to granular, non-granular. We are not able to remove these with snares because they will slide over the polyp. The snare will slide over. So what we do is punching using cold forceps, plus by the tip of the snare we do coagulation. This procedure called cast, and one of the classic treatment for the lateral spreading tumor. The cast stand for cold forceps avulsion with adjuvant snare tip coagulation. Okay, let's move to snare. Okay, snare or snares, actually it's using a wire to remove the lesion. As you see here, this is a snare. Actually, this is a snare. Also, we have cold snare and hot snare, the same principle. Hot snares use electrocoagulation for removal, where cold snares use only the wire to remove the lesion. When we want to compare snares to forceps, which we already talked about, so snares is better regarding that we can take larger, more tissue. The completeness of the resection, especially in small polyps, is better with snares. You can see here in one study they noticed that polyps less than 6 millimeter, when we use snares we remove up to 93, while forceps using just punching avulsion we remove only 75%. If we want to compare cold snare and hot snare, as you see here, this is hot, this is because here we have actually this is hot snare, this is cold snare, the same principle. Hot snare can cause damage to the tissue around and may present with delayed bleeding, while cold snare may cause bleeding, but the bleeding due to the cold snare will be immediate while you are in the procedure, so you can manage it on a spot. It's preferable to use cold snare. We have now what we call it the tailored or dedicated cold snare. What do we mean by dedicated cold snare? We make the wire extremely thin, and so that it can grasp and cut the tissue better. If we want to compare hot snare and cold snare regarding the completeness of resection, the same. There are specific indication for hot snare. These are pedunculated lesion and sessile lesion that are greater than 1 centimeter. Okay. Other lesion are better to be taken by cold snare. What else we can add? We said that bleeding immediate after cold snare and delayed after hot snare, and the problem with delay that it needs re-evaluation again up to 1 month the bleeding can present. Okay, let's move about some tips of optimal and ideal snaring. Okay, and one of the tips that you have to remember that the biopsy channel from which the forceps or the snare will come out is in the bottom of the tip of the scope, so keep the at 5 o'clock approximately, so keep the polyp at the bottom of your screen. We have different shape and of snares as you see here. We said that we have hot, and what we didn't mention in hot snare, please do some kind of lifting, elevate the tissue so that you will not cauterize the healthy underlying tissue. We will talk in details about lifting in the next few seconds. Okay, we talked about that forceps, its jumbo is better than the standard. We talked about, if we are talking about cold snare, the dedicated snare, the thin wire is better than the traditional one. Here we have different type of snaring: oval, hexagonal, needle tip, we have a needle here, etc. Okay, we have, after removal of any polyp, to assess, do we remove the lesion completely? And what I can see here, that we have two main risk factors for incomplete resection. These are the size, the larger the size, and if we are talking about adenoma, we have two types: adenoma, the classic, and sessile polyp. These carry the malignant potential. So sessile serrated polyp are at higher risk for incomplete resection when we compare it to adenoma. We talked about lifting, and we said when we use a hot snare kind or any kind of cauterization, some lifting is required. What do we need to add? Okay, as we said, one of the indication for lifting is when we use hot snare in order to avoid thermal damage. Another indication is that the lesion itself is flat, so we need some kind of elevation in order not to cause injury to the muscle of the colon, to avoid full thickness mechanical disruption. So flat lesion, hot snares. Okay, we have different agents of them. For example, saline. We can use saline to create this lifting or this space. Hyaluronic acid, glycerol, albumin, etc. Saline is ideal regarding when we compare it to all other religion, regarding the completeness of the resection, regarding the post-procedural bleeding, post-polypectomy syndrome perforation. The disadvantage of saline that it gives you only elevation for a short time, only 3 minutes. So it's appropriate for rapid procedure. But if we want to proceed for more complex procedure, we need more durable solution that will give us additional time to work. For example, of this agent, for example, hydroxyethyl stretch, HETA stretch. It's of course expensive than saline. Eleview These are agents that give you elevation up to 40 minutes or ice. So we may use this agent, for example, in endoscopic mucosal or submucosal dissection. The technique how to inject, actually I don't want to go in the detail, but we use the tangential technique. We do not go perpendicular, we go parallel, we inject slowly at the beginning to achieve a taller elevation, tall and focal elevation. If it wasn't tall and separate, so you are not, and all over, so you are not in the correct space. The same principle of tattooing also applied here. What else I can, if for example I inject the lifting agent but no elevation achieved, many causes. This may be due to incorrect plane, you are in the muscle of the colon, or there is a previous scarring due to polypectomy, or there is an advanced mass that is beyond the submucosa. So this is one of the reason of non-lifting, let's say. Of course, the location of giving the lifting agent may be missed. Okay, let's talk about endoscopic mucosal. We talk about simple polypectomy by snares, by forceps. Now we will talk about two important entities. These are the endoscopic mucosal resection and endoscopic submucosal dissection. Endoscopic mucosal resection, I want you to imagine removing a polyp is like a ladder. We go step up. We can use it by simple polypectomy using either forceps or snares, and if not, we move up to endoscopic mucosal resection. Endoscopic mucosal resection is indicated for lesion up to 2 centimeter. Yes, I know that it's written here that regularly used for polyp ranging from 2 centimeter to 5 centimeter, but it's ideally, we will see, ideally for lesion around 2 centimeter, lesion that are flat, and lesion that are sessile. Okay, these are the three type of polyps that endoscopic mucosal resection is indicated. We use in this technique the hot snare mainly. So what we need is a lifting technique or lifting agent, and the technique we use is, as it's written here, the most common endoscopic mucosal resection method is lift and cut. Lift using a lifting agent, and which we described it a few seconds ago, and we cut using what? Snare, hot snare mainly, or let's say, okay, sometimes they use cold snare, but we already we used a lifting agent that can protect the underlying structure, so it's hot snare. What I want to add, also we use some dye just to guide our plane of dissection. As you see here, this is serrated polyp that they inject a lifting agent with dye, as you see here, and the clip is not routinely, but closure, the defect is upon the endoscopist preference. What else I want to add about endoscopic mucosal resection, that sometimes it is not removed in a one piece, but in what we call it a piecemeal snaring. Actually, we remove part, then we go to the edges of the last part and we remove it. But it's preferable to use few snaring. Why? Because this will actually prevent the histopathological exam, and this is one of the disadvantage of endoscopic mucosal resection, that even with the usage of a large snare, even with the use of, we may need to remove the lesion in pieces, and this will prevent histopathological assessment. And this is why for lesions that are larger than 2 centimeter, it's not preferable, because lesions that are larger than 2 centimeter carries a risk for malignant potential and mandatory to pathologically assess these lesions. What else I want to say? One of its disadvantage that we cannot remove them in block as one piece, in pieces. Yes, we have large snare, but even it's not large enough to remove the lesion in one piece. This is the secret behind why we recommend, or it's preferable, that endoscopic mucosal resection is up to 2 centimeter only. Sometimes they use the APC coagulation, argon beam coagulation, not recommended, because while endoscopic mucosal resection, because it destructs the surface of the polyp. It's what I can classically deliver to you, that it is not recommended associated with recurrence. If we are talking about the recurrence, we have risk factor for recurrence after submucosal, endoscopic submucosal resection. These are, as you see, the size more than 2 centimeter, the usage of argon beam coagulation, and the presence of bleeding. I hope you get it. What I want you to remember, endoscopic mucosal resection, did I say that the margin should be 2 to 3 millimeter? If not so, please add it. A margin of healthy tissue of 2 and 3 millimeter. So it is a step up when we compare it to simple polypectomy, indicated for lesion that is around 2 centimeter, flat, sessile. We use hot biopsy, so we need lifting agent. We use a snare, a hot snare. So one of the disadvantage that we cannot remove it in a block, we remove it in a piecemeal, and this prevents the histopathological assessment. We sometimes use dye. And let's move a step up to the clip. We already talked about the clip. We said that the clip is not recommended routinely. The purpose behind the clip in endoscopic submucosal resection is to close this defect, huge defect, and to prevent bleeding. We have two main clear indications. Let's see. Either the lesion is larger than, that the defect is larger than 2 centimeter, and the location is in the proximal colon. As you see here, these are the polyp is larger, not the defect. The polyp is larger than 2 centimeter and in the proximal colon, for example, in the ascending colon. So it's proven to decrease bleeding, to decrease the incidence of post-polypectomy syndrome when we compare it to left colon endoscopic mucosal resection, the clip is not beneficial. Okay, what else about the clip? These are the clip, how they look like. Two purposes: closure of the defect if the polyp is larger than 2 centimeter, location in the right column. I want to move fastly to compare to show you what do we mean by endoscopic submucosal dissection, but one of the technique that is only 20 years ago discovered or proven to be beneficial is what we call it the underwater endoscopic mucosal resection. Okay, underwater endoscopic mucosal resection is a modification of the endoscopic mucosal resection, the classic one. You notice that mislocation of injection of the lifting agent is common. We may go deeper, and this may be devastating regarding the injury, perforation, bleeding. For this, the concept of underwater endoscopic mucosal resection, we avoid injecting a lifting agent, but the other principles are the same regarding, for example, the hot snare. We use a hot snare in the underwater endoscopic mucosal resection. It's preferable for larger lesion. We will see why. You can see here that the working field is filled with half to 1 liter sterile water, and using the same principles we provide a hot snare and we remove it with no lifting. It's proven that the completeness of macroscopic excision is better, and what also proven that the recurrence is less compared to the classic endoscopic mucosal resection, but of course it need more time. It need to deflate the gas in stale water. It give advantage in that it flatten the bowel wall, so make the work easier. What else? It's the same principle underwater can be applied to, as we will see in the next few seconds, endoscopic submucosal dissection. One of its advantages also, it decreases the risk of burn due to the hot biopsy. One of the advantage also is that the partially cutted edges of the lesion can float in the water, making the dissection or resection easier. Sometimes we use it as a salvage. What do we mean? If classic endoscopic mucosal resection doesn't work, we go to underwater endoscopic mucosal resection. Okay, let's move to endoscopic submucosal dissection. And imagine again, removing of a polyp, of a lesion, serrated polyp. It's like a ladder. We go from the simple procedure, simple polypectomy, using forceps, punch, or using cold forceps, or using snares. Then we go from simple polypectomy to endoscopic mucosal resection, and one of its variant is underwater endoscopic mucosal resection. And now we reach the endoscopic submucosal dissection. It's clear that in endoscopic submucosal dissection we go a little bit deeper when we compare it to mucosal resection. And if you remember, when we talk about endoscopic mucosal resection, one of its disadvantage was that when we remove the lesion using a snare, we may be not able to remove the lesion as an en bloc, and this will limit the histopathological examination. And in mucosal resection, we remove it like a piecemeal. In endoscopic submucosal dissection, we use electrosurgical knife, so we can use larger lesion as en bloc, and it is better regarding the histopathological assessment. Actually, endoscopic submucosal dissection is harder to learn, more complication as we will see, and it was first described in Japan for early gastric cancer, and actually the gastric tissue and the gastric mucosa and is more thicker and easier, but then developed to the colonic endoscopic surgical dissection. When we want to compare it to mucosal, of course, the recurrence rate is lower, but the perforation rate is higher in endoscopic submucosal dissection. You can see this picture, nice picture, but do not look to the details. What I want you to know that here we use a knife. Okay, we have different type, but actually here we use a knife, not a snare. We have the hybrid procedure in which we use a snare. Please remember, here we are talking about a knife. We are talking about going deeper in the bowel wall, so perforation is higher. And what else I want to say regarding that? Okay, of course, when we want to compare it to the laparoscopic surgery or laparoscopic resection, so of course this is an endoscopic submucosal dissection, or what we call them the endolumenal surgery, have lesser hospital stay, better patient satisfaction, less cost. So this is when we compare it to laparoscope or open surgery. The complication, always remember, endoscopic submucosal, we go deeper, risk of perforation is higher, this is one. Risk of bleeding is higher. I mean higher when we compare it to mucosal resection. You can see here that complication may be abdominal pain, bleeding, perforation, and tumor recurrence. One of the unique complications related to endoscopic submucosal dissection, do you remember that we said that we use a knife, electrosurgical knife? So we have what we call it the post endoscopic submucosal dissection electrocoagulation syndrome. It is the same as the post polypectomy syndrome. It is constellation of abdominal pain, fever, leukocytosis without perforation, and it's up to 40 of the patient and treated conservatively. Bleeding also up to 7%. Perforation also higher when we compare it to endoscopic mucosal as we go deeper. What else? The recurrence rate is low, and the patient selection is extremely important. Who is capable for endoscopic submucosal dissection and who is not, who need traditional laparoscopic surgery or a traditional open surgery? Do you notice that we call the laparoscopic surgery traditional now because we are talking about the endolumenal surgery? And keep it in mind that polyp less than or up to 2 centimeters is best treated with mucosal. As you see here, if lesion less than 2 centimeters, so endoscopic mucosal resection is better. Actually, More than that, we start size. More than that, we start to think of submucosal dissection. Actually, patient selection, if we want to go a little bit back, depends on the size, as we say, that less than 2 centimeter go to mucosal, above think of submucosal. The second factor that determine the patient selection is the risk of malignancy. We do not want to proceed with endoscopic submucosal dissection in malignant lesion. Malignant lesion may have potential to spread to lymph node, and we cannot control lymph node metastasis endoscopically. So, if we want to say more clear, patient who have lesion that are more than 2 centimeter, let's say polyp more than 2 centimeter, with no sign of malignancy. If there is sign of malignancy, how I can determine the sign of malignancy, we will see. But with no sign of malignancy. If the diagnosis is unclear, we can proceed. We can proceed for endoscopic submucosal resection. Okay. We said, again, I'd like to repeat. Size, more than 2 centimeter, less than 2 centimeter mucosal, more than 2 centimeter submucosal, and risk of malignancy. But endoscopically, how we can determine the risk of malignancy, how we can say, oh, this is malignant or this is not malignant. There are many classifications that depends on the appearance, on the morphology of the polyp, in which if they are malignant, I will not proceed. That is the call. We will not concentrate on this detail because we will have a lecture that we will explain how we should manage malignant polyp. But just to tell you that we have different classification of them. The Paris classification. This is Paris classification. They classify polyp according to the protrusion, protruded, flat, slightly elevated, even excavated. These lesions which are depressed have a higher risk for invasion. So this is one of the classification on which we depend to determine the risk of malignancy. Other classification is what we call the Codopit pattern. The Codopit pattern actually a Paris classification, just to tell you, it classifies it to polypoid and non-polypoid, and it's a matter of another lecture, but this is how the Paris classification. The pit pattern, actually this is a slit over the top of the polyp that take many shape, and according to that shape I can predict the risk of malignancy, and so the malignant lesion I will not proceed with endoscopic submucosal resection or endoscopic submucosal dissection or endoscopic mucosal resection. You can see here, for example, these are the pit, the slit over at the top of the polyp. We have round pit, astroid, tubular, dendritic, tubular and round, irregular, etc. And finally, they can be classified to hyperplastic, adenomatous, malignant. We do not want to touch the malignant lesion at all. Okay, another classification that will help us to determine endoscopically this is malignant or not is what we call it the narrow band imaging. The narrow band imaging, actually it's using a light consisting of a green and a blue, and according to that light we can predict the malignant risk. This is determined by the vascularity of the polyp. For example, you can see that hyperplastic polyp look over here looks like the normal background. It looks like blue and green color, whereas adenoma, you can see that it looks brown. So, oh, this is malignant, do not touch. And also this is a cancer, looks also brown over here, brown to black. So this is like filtering the light according to the vascularity. Again, I don't want to disturb you about this information because we will discuss them well in a lecture called Management of Malignant Polyp. Even this picture, I bring them from that lecture. Just what I want to you finally to know, that patient selection for endoscopic submucosal dissection is dependent on size, more than 2 centimeter, and risk of malignancy. Malignant lesions are incapable for endoscopic submucosal. Okay, endoscopically, how I can determine is this malignant or not? According to the 3 classification: Paris and Codopet pattern and the narrowband image. Another technique that can help me in determining intraoperatively or not in the procedure is that malignant or not is the ability to lift. We said that we may use lifting agent, injected lifting agent. If the lesion cannot be lifted, so maybe there is invasion even to the submucosa and even deeper. And if I cannot lift the lesion, so please stop. This is maybe malignant, and it's better to refer it to the surgeon for formal resection and anastomosis. But depending on the ability of the lifting of the lesion is not specific, because yes, non-lifting the lesion may be due to invasion to the underlying vessel, but maybe due to scarring, simple fibrosis, due to inflammatory process. So it's matter of you have to balance, and the decision intraoperatively is not that easy. About the technique, we said the main difference between mucosal and submucosal. Mucosal, we use hot snare. Submucosal, as we will see, we use knife, and for that reason we can use larger tissue. The technique of endoscopic submucosal dissection, again they mention the indication ideal for polyp that are larger than 2 centimeter, where invasion is not suspected. In this category will fall the lateral spreading tumor frequently or polyp. Okay, the technique as you see in this picture, first of all we use a knife. We do not use forceps or snares. We do a marking around the lesion. The margin should be about 2 to 3 millimeter, and then we use a lifting agent as you see here, but as we said, durable agent that will last, because this is a long procedure when we compare it to polypectomy. Then we start to dissect the tissue from the distal or anal side and we go tangential, parallel to the submucosa, and then we remove it in an block for histological examination. This is what we call it the classic endoscopic submucosal dissection. We have the hybrid. What do we mean by hybrid? Once we reach here, we can use a snare. But if we use a snare, it's like a mucosal dissection. So this is what we meant by this picture when we talk about the hybrid procedure. You see, hybrid endoscopic submucosal dissection. Finally, they use a snare, but in the classic one, they continue using the knife. Actually, the hybrid procedure is associated with higher recurrence, and this is logic. This is the classic is better. Of course, this need learning and not as easy as submucosal. What else? We may need to position the patient in order to keep the edge away from our field. What else we can add regarding that? The defect. You see that finally we may have a large defect. It can be closed either by clipping. I think I have a picture here. Clips, over the scope clip, suturing, whatever. If we are talking about at which location it's better in the colon to proceed in endoscopic submucosal dissection, so it's in the rectum, because we have the mesorectum, in which it can help us if there is a small defect, so it will seal it, it will close it. Okay, of course the reminder of the information is just they told you how it's hard to learn, and it needs a learning curve. What else? Okay, another thing. This is when we talk about the post-operative care. Of course, the endoscopic mucosal resection, the patient can discharge at the same day home, while in endoscopic submucosal dissection, it is preferable from overnight observation. No need for antibiotic, no need for any dietary restriction. The patient can resume his oral diet, her oral diet. No need for any x-ray unless there is a difficult procedure and suspected perforation. Okay, dear colleague, this procedure such as ESD, EMR are new procedures, so the indication and contraindication is developing, and there are controversies. There are points that is not clear to proceed with that or to proceed with that, or send the patient to traditional open or laparoscopic surgery. We said that one of the clear indication to endoscopic submucosal dissection is polyp larger than 2 centimeter and no sign of malignancy according to the classification we already talked about, which we can determine endoscopically. But the question, what is the rate of having malignancy in these patients? A patient with a large polyp, more than 2 centimeter, with no endoscopic sign of malignancy, do I need to remove it? Because the risk of invasive malignancy is even less than 10 centimeter. So this is one question. Second question, when we want to compare ESD or endoscopic submucosal to mucosal, submucosal is harder to learn longer time, more complication. Yes, it is less recurrent, but the recurrence with endoscopic mucosal resection can be controlled endoscopically with the follow-up surveillance endoscopy. So, is it mandatory to proceed to endoscopic submucosal dissection in indicated patient, or to be safe and proceed only to endoscopic mucosal resection? Another question, or another disadvantage of mucosal resection is that we cannot remove large lesion using a snare as a one piece and a block. So the mucosal resection will actually prevent our proper histopathological examination. So these are different questions or points that show you how this science is developing nowadays. Of course, there are some level of invasion that can be malignancy with level of invasion that can be treated with endoscopic submucosal dissection, such as in this, as you see, superficial carcinoma that invade upper third of the submucosa, that mean less than 1000 micrometer, or we call it submucosa 1 according to one of the classification, can be cured by endoscopic submucosal dissection. But actually these are a very narrow population. These are limited population. So this is what they mean by controversies with ESD versus EMR and traditional surgery. This was one item that we can use in endoluminal surgery. Now there are other techniques that we can use in endoluminal surgery, such as suturing and stenting. Okay. Of course, any defect, large defect, or if there is suspected perforation, especially those that are related to our endoluminal intervention, such as post endoscopic submucosal resection or mucosal resection or submucosal dissection or polypectomy, these can be treated with clips or better with stitch. We have different models. As you see here, we have the over stitch, in which there is a grasper to grasp the tissue and take a stitch over here. It can prevent the patient from the overnight observation and to be discharged safely. Actually, this is the overstitch. It requires dual channel endoscope. If you remember in the previous lecture, we said that some colonoscope have two working channel, so that we can pass the grasper and we can pass the needle. This is regarding the suturing related to our iatrogenic injury. Stabilization platform, this means that we are working in the colon where there is multiple folds, where there is frequent motion. So we may need to fix the working field, and one of the solution is to use the double balloon endoscope. Actually, it may be just a tube over the colonoscope that provide double balloon, so fixation between the balloon and working there. Here is the dilumen, as you see here. This is double balloon, and we have also another technique for stabilization called the Ori's tissue retractor system. This is it. It actually stabilize the colon, open it, and as you see here, provide good field for working. This is how double balloon fixation, and this is Ori's platform. I think at this point a more experienced endoscopist can talk. Okay. When we do refer patient to surgeon, we already said if the lesion doesn't fit with our criteria, for example, it looks according to the endoscopic classification, the morphology of polyp, malignant, so it's preferable to send it to the surgeon for formal resection and anastomosis, open or laparoscope. This will depend on the photo documentation, because Paris classification, Codopet classification, and narrow band imaging classification all depend on photo documentation, so should be discussed with the surgeon. If malignancy is suspected, refer to surgeon. Of course, we have the hybrid procedure or combined procedure. We can proceed with combined endoscopic and laparoscopic surgery. Okay. Nothing else. Simply, who I should refer? Those who doesn't fit my criteria for polypectomy, endoscopic polypectomy, for endoscopic mucosal resection, and endoscopic submucosal dissection. Colonic stent, we already talked about colonic stenting in the large bowel obstruction lecture, but let's review what the most important information. Here we are talking about large bowel obstruction. Historically, this patient was treated with just bringing a stoma to evacuate the abdomen, because in case of intestinal obstruction there will be edema, emergent surgery, how do we call it, the one large lumen discrepancy in the diameter of the bowel, so anastomosis is not available because one diameter will be smaller than the other. But with the invention of stenting, we use them in a tumor as a bridging surgery. Yes, it may be used for palliative, as we will see. We have two indications. Either it is bridging to surgery if there is obstructive tumor in the left side of the colon, or a palliative for malignant large bowel obstruction. The type of stent we use in the colon is self-expanded uncovered. Why? Because the covered will prevent the invasion, and we need this type of invasion to keep the stent in place, because one of the complications is migration. So we use uncovered self-expanded stent. What else we can add? No rule for prophylactic stenting. The complication could be perforation, migration, or again obstruction due to malignant invasion. Again, the risk of, when we compare patients who are treated with bridging stent to those who undergo surgery, the risk of local recurrence is higher in those where we use stenting. This is maybe one of the causes that we do not prefer bridging therapy with a stent in a healthy patient. Some studies says that stenting is preferable as a bridging if the ASA is more than 3. I think it's written here. Anesthesia score more than 3 and the age is 70. This is because when we use the stent, the risk for local recurrence is higher, so it's not needed for healthy patient. This is not an absolute information because some studies proven that similar rates of local recurrence. What we need, of course, we need type of contrast study to know the degree of stenosis, the length of the tumor, the site of the tumor, if the contrast either by barium enema or CT contrast enema, if the contrast cannot bypass the tumor, so unfortunately the stent cannot be inserted. The wire before inserting the stent cannot be inserted. If the obstruction in the large bowel is due to extraluminal compression, whatever the cause, metastasis, extraluminal, so unfortunately again the stent will be not helpful because fixation the stent in its site depends on kind of mucosal abnormality, kind of invasion to the stent to be in its site. Okay, the technique of stenting. Okay, regarding the technique, we said we should start with contrast study, either contrast enema, fluoroscopy or CT, to check that the contrast can travel through this obstruction. And our insertion should be under fluoroscopic guidance. We use the longer stent, the wider stent that we have, and as you see in this picture, first we insert the guide wire, over it we insert the stent in a sheath, and it's preferable to give 5 centimeter distal from the lesion, so, and there will be actually a clip here that will tell us that we reached the 5 centimeter proximal to the lesion. We use, as we said, uncovered stent. What else we can add? No need for balloon inflation. It will expand alone within 2 days. No need to reinsert the scope again. This may cause migration. In the first 2 days, we may use some kind of stool softener. X-ray is required after placement, and as you see in this picture, this is how it looks like. Another indication for stent placement, as we discussed in the anastomosis lecture, is anastomotic leak, especially if we are talking about contained leak or fistula, but in this case we use covered stent in order to prevent leakage. Of course, the migration here is higher, but even if migration happened after 20 or up to 50 days, leak may be controlled or fistula may be controlled or appropriate for surgery, and the success rate with the treatment of contained anastomotic leak or fistula with stenting is between 80 to 100%. Thank you for watching this lecture. We talked about endoluminal surgery and some technique that we can use. Thank you. Bye bye.